So if you take this particular anticholinesterases, so in the organophosphorus poisoning, like what we have discussed is the individual will have hypotension and as well as bradycardia. But remember, in case of the nicotinic receptors, if they are stimulated, normally a point that you should remember is the acetylcholine will reduce the blood pressure of the individual or will reduce the heart rate of the individual. But if that particular acetylcholine, if it goes and binds with the nicotinic receptors, right? If it stimulates the nicotinic receptors, what you have to remember here is stimulation of these nicotinic receptors will result in increase in the heart rate of the individual and as well as increase in the blood pressure of the individual, right? Increase in the heart rate of the individual and as well as increase in the blood pressure of the individual. So remember, blood pressure and heart rate may increase rarely due to stimulation of the nicotinic receptors by the acetylcholine. Otherwise, acetylcholine will decrease the heart rate of the individual. Alright? Next. Now, in these patients with the organophosphorus poisoning, now what is the treatment? Right? In these patients with the organophosphorus poisoning, what is the treatment? Remember, now which levels are increased by this organophosphorus poisoning? The acetylcholine levels, they are grossly increased. Now, what is the substance which will neutralize the action of the acetylcholine is the anticholinergic drug, because your acetylcholine is a cholinergic drug. Right? It is a cholinergic drug. A point that you should remember is you have to give an anticholinergic drug in order to neutralize the action of the acetylcholine. So what is the drug which we give is atropine. So remember, atropine, which is an anticholinergic drug, right? Which is an anticholinergic drug. This is the drug of choice for organophosphorus poisoning, right? This is the drug of choice for organophosphorus poisoning. Now, this atropine is not only the drug of choice for organophosphorus poisoning, it is also the drug of choice for organocarbamate poisoning. Right? Even in case of the organocarbamate poisoning, this atropine is the drug of choice. Next. Now, remember another very important point here. Apart from atropine, right? Apart from atropine, we have some other drugs which are used in the treatment of organophosphorus poisoning. And what are those drugs? Those are the enzyme reactivators, right? Those group of drugs are enzyme reactivators. So, the other group of drugs which are used in the treatment are enzyme reactivators. Now, you take this particular enzyme reactivators. These enzyme reactivators, these drugs they include, the examples are, right? The examples are the pralidoxime, then you have, right? Then we have the obidoxime. Then the other drug what we have is diacetyl monooxime, right? Diacetyl monooxime. So these are the enzyme reactivators. So we call these particular drugs as the oximes. Right? We call these particular drugs as oximes. So what these particular oximes will do, remember these oximes will regenerate the acetylcholine esterase, right? These oximes will regenerate the acetylcholine esterase enzyme. Okay, these oximes will regenerate the acetylcholine esterase enzyme in case of the organophosphorus poisoning. But a point that you should remember is these oximes we can use in case of OP poisoning. Right, these enzymes we can use in case of organophosphorus poisoning. But a point that you should remember is these enzymes, they are contraindicated. Okay, these enzymes, they are contraindicated in case of the organocarbamate poisoning. Right, these are contraindicated in case of organocarbamate poisoning. Why they are contraindicated in organocarbamate poisoning, I will explain you. Next, the another point is, now what are the indications for the enzymes? Why we have to give enzymes? Remember, the principal indications of the enzymes, right? The principal indications of this particular enzymes are, there are two prime indications. The prime or principal indications are, number one, muscle weakness. Right, number one, muscle weakness, and the other indication is respiratory depression. Right, the other indication is respiratory depression. So these are the two principal indications for the enzymes. So remember, the drug of choice for organophosphorus poisoning and as well as the organocarbamate poisoning is an atropine, which is an anticholinergic drug which will neutralize the action of the cholinergic drug, that is acetylcholine. And the other group of drugs which are given as a part of the treatment in organophosphorus poisoning is enzyme reactivators. They are nothing but enzymes. You take these particular enzymes, they include pralidoxime, obidoxime and as well as diacetyl monooxime. These particular enzymes, they will regenerate or activate the acetylcholine esterase enzyme. Now a point that you should remember is these particular enzymes, they are given only in case of organophosphorus poisoning, but they are contraindicated in case of the organocarbamate poisoning. Now the indications of these particular enzymes are the muscle weakness and as well as respiratory depression. Now let me explain you why these enzymes are contraindicated in case of organocarbamate poisoning. Now let me tell you why these particular enzymes are contraindicated in case of organocarbamate poisonings. Now you take this particular cholinesterase enzyme. Right, this particular cholinesterase enzyme, it has two sites, the two important sites. One is the anionic site, right? One is the anionic site, and the other site in this particular the cholinesterase enzyme is the esteric site. Right? There are two important sites for this particular cholinesterase. One is the anionic site and the other one is the esteric site. Now, you take these particular compounds or you take these particular enzymes. The site on which the enzymes will bind and reactivate this cholinesterase enzyme is the anionic site. So, the enzymes, right, enzymes, they bind at, right, they bind at the anionic site and will activate the cholinesterase enzyme. Now you take this organocarbamates and as well as the organophosphates. If you take this organophosphates, right, if you take this organophosphates, these organophosphates, they will inactivate this cholinesterase enzyme by binding to esteric site. Okay, organophosphates will inactivate the cholinesterase enzyme by binding to the esteric site. Organophosphates, they don't bind with the anionic site. Now, how is this cholinesterase enzyme activated by the enzymes? the enzymes, they will bind to the anionic site and will activate the cholinesterase enzyme. Now to this particular anionic site, the organophosphates, they are not bound, right? They are not bound. So organophosphates, they bind to the esteric site only, whereas you take this particular carbamates, right? Whereas you take this particular carbamates. If you take this particular carbamates, they bind to both. They bind to the esteric site. They also bind to the anionic site. Right? They bind, which one? The carbamates, they bind to both anionic site and as well as the esteric site. Now you see here, when carbamates, when they bind to the anionic site, now the enzymes cannot replace the carbamates which are present on the anionic site. I'll repeat again. When carbamates, when they bind to the anionic site, when you give enzymes to activate the cholinesterase enzyme, the enzymes cannot replace the carbamates which are bound to the anionic site. That is the reason why the enzymes, they are not indicated in patients with organocarbamate poisoning. Is that clear? That is one reason. The other reason is, right, the other reason is further enzymes themselves, they possess, right, they possess weak acetylcholinesterase enzyme inhibitory action, right? Weak acetylcholinesterase enzyme inhibitory action. Okay? Because of these two reasons, the enzymes should not be given in case of organocarbamate poisonings, right? The enzymes should not be given in organocarbamate poisoning. Alright? So that is the story why the enzymes should not be given in case of the carbamate poisoning. Now, I have discussed that there are three enzymes. One is diacetyl monoenzyme, then pralidoxime, and then obidoxime. You take this particular diacetyl monoenzyme. Diacetyl monoenzyme, it can cross the blood-brain barrier and it will regenerate the acetylcholinesterase enzyme. So remember this, we have diacetyl monoenzyme, right? Diacetyl monoenzyme. Then we have pralidoxime. Then we have obidoxime. Okay, you take this particular diacetyl monoenzyme. The diacetyl monoenzyme, this will cross the blood-brain barrier, right? This will cross the blood-brain barrier and will activate, right? Will activate the acetylcholinesterase enzyme within the brain, that is within the central nervous system. Whereas you take the pralidoxime and as well as obidoxime. This pralidoxime and as well as obidoxime, they cannot cross, right? They cannot cross the blood-brain barrier, right? So this is a very, very important point. Is that clear? Next. So that is about the story of your entire enzymes. Now, apart from this particular, the organophosphate and as well as organocarbamate poisoning, let me tell you, there is one important organophosphate drug that is called as triorthocresyl phosphate, right? There is an important organophosphorus compound that is called as triorthocresyl. Okay, so we have an important compound which is called triorthocresyl phosphate. So if you take this particular triorthocresyl phosphate, what actually is this? Remember, it is an additive in the lubricating oils. right? In lubricating oils, this is one of the additive agent. Now what this particular triorthocresyl phosphate will do is, this chronic exposure to this particular triorthocresyl phosphate will cause delayed neuropathy. This is one of the very important multiple choice question. Will cause delayed neuropathy. Now, how do you think there will be development of delayed neuropathy? Now, this particular delayed neuropathy will appear 1 to 2 weeks after the exposure of the drug. Right? This particular delayed neuropathy will appear 1 to 2 weeks after the exposure of this particular triorthocresyl phosphate. Now, delayed neuropathy is mainly, it is associated with, why is this happening is, it is associated with demyelination of the axons. Right? It is associated with the demyelination of axons. Right? That is one very, very important point. Now, what you have to remember, another important point is, you take this organophosphate poisoning. Organophosphorus compounds, what are they doing? Apart from triorthocresyl phosphate, this is also an organophosphorus compound. What are your organophosphorus poisonings doing, or organophosphorus compounds like the parathion and malathion they are doing? They are inhibiting the enzyme, the cholinesterase. That is the reason why you are having the actions of exaggerated pharmacological action of the acetylcholine. Whereas the triorthocresyl phosphate, it will cause delayed neuropathy by not causing the inhibition of the cholinesterase. Rather, this triorthocresyl phosphate will inhibit what is called as neuropathy target esterase enzyme, which is present within the axons of the nerve. Right? So, this triorthocresyl phosphate will inhibit an enzyme which is called neuropathy target esterase. Right? Will inhibit the enzyme called neuropathy target esterase. So, due to inhibition of this enzyme by your triorthocresyl phosphate, the individual will develop delayed neuropathy. Right? The individual will develop delayed neuropathy. This is a one very, very important question. The triorthocresyl phosphate will cause delayed neuropathy by causing the inhibition of neuropathy target esterase, but not inhibiting the cholinesterase enzyme. Alright? Next. Now, you take this particular organophosphorus poisoning. These organophosphorus poisoning, in these individuals, there is development of a syndrome which is called as the intermediate syndrome. Right? There is development of a syndrome which is called as the intermediate syndrome. Now, this intermediate syndrome, it will occur after 1 to 4 days. Right? It will occur after 1 to 4 days of the organophosphorus poisoning. And this particular intermediate syndrome, it is caused by the cholinesterase inhibition. Right? It is caused by the cholinesterase inhibition. Okay. So this is completely about your irreversible anticholinesterases. Right? Let me shortly revise what I have discussed until now. Now, what I have discussed is these oximes, they are contraindicated in case of carbamate poisoning. Why? Because you take this cholinesterase enzyme, it has two important sites, that is anionic site and as well as the esteric site. The oximes will activate the cholinesterase enzyme by binding to the anionic site. And you take the organophosphorus compounds, they will inhibit the cholinesterase by binding to the esteric site. So, in organophosphorus poisoning, the oximes can bind with the anionic site to activate the cholinesterase enzyme. Whereas, in organocarbamate poisoning, that is carbaryl and propaxure poisoning, the carbamates, they bind to the anionic site and as well as the esteric site as well. So, the enzymes cannot replace the organocarbamates which are bound to the anionic site. That is the reason why the enzymes are not given in organocarbamate poisoning. Not only that, these enzymes, they have weak acetylcholinesterase inhibitory action. Because of these two reasons, they are contraindicated in case of organocarbamate poisoning. And we have three important enzymes, that is diacetyl monoenzyme, pralidoxime and obidoxime. Diacetyl monoenzyme can cross the blood-brain barrier and will activate the acetylcholinesterase enzyme within the brain, whereas pralidoxime and obidoxime, they cannot cross the blood-brain barrier. And we have another important organophosphate, chronic exposure of this particular organophosphate, that is the triorthocressyl phosphate, which is used, which is an additive in the lubricating oils, they will cause the delayed neuropathy. Chronic exposure in the sense, after 1 to 2 weeks, this triorthocressyl phosphate will cause the delayed neuropathy. And the delayed neuropathy caused by this triorthocressyl phosphate is due to inhibition of neuropathy target esterase. Next, the other important thing is, you take this particular intermediate syndrome occurs in organophosphorus poisoning after 1 to 4 days. And this intermediate syndrome is due to inhibition of the cholinesterase enzyme. So this is completely about your irreversible anticholinesterases.